Now, next in the line is the ulnar nerve. Now, guys, let's talk about the ulnar nerve. We'll go the same way. First, we'll look at the major course of the ulnar nerve, and then we'll look into the injury, the difference in the higher injury and the lower injury of the ulnar nerve also. The root value for the ulnar nerve is different from the median nerve and radial nerve. Radial nerve and median nerve was C1, C5, C6, C7, C8, and T1. Ulnar nerve root value is just C7, C8, and T1. So root value is different. That is C7, C8, and T1. Just like median nerve, ulnar nerve is also not supplying anything in the axilla or in the arm. So supply of the ulnar nerve also begins below the elbow. We already discussed the proximal course of the ulnar nerve. If I remind you again, we saw that ulnar nerve starts from the medial cord of the brachial plexus. So it is medial to the axillary artery, continue medial to the brachial artery, pierces the intermuscular septum, goes behind the medial epicondyle, and then will into the forearm. So again, I got to start the discussion from the lower end of the humerus only. So once again, if this is the lower end of the humerus here, and this here is the medial epicondyle. So as we discussed already, that ulnar nerve will be seen passing behind this medial epicondyle, and then it comes into the anterior compartment, because ultimately ulnar nerve has to supply the muscle of the anterior compartment of the forearm only. How will it come in front? It will come in front by passing between the two heads of the muscle, and that muscle is flexor carpi ulnaris. Flexor carpi ulnaris is also having two heads. One is humeral head and one is the ulnar head. So there is a superficial and deep head. Let's not go into that detail. I'm just drawing it like if there is a muscle here which is having two heads. This muscle here is the flexor carpi ulnaris. Very important muscle in here. So this ulnar nerve, it will pass between the two heads of flexor carpi ulnaris, and then it will come into the anterior compartment of the forearm. Will supply few muscles in there. The nerve will be seen passing superficial to the flexor retinaculum. We already discussed that in the retinaculum part. So that is, if this is a flexor retinaculum, the ulnar nerve will pass superficial to it. Then what you will see, the ulnar nerve, it goes through a canal in this region here. That canal is called as a Guyon's canal. I'll tell you more about it. Let me just draw it. That is Guyon's canal, where you can see the nerve is dividing into a small superficial branch. I'm writing SB, that is a superficial branch. And we have this long deep branch of the ulnar nerve. The superficial branch and the deep branch of the ulnar nerve, SB and DP. Just draw this with me first. So ulnar nerve, first we saw it is passing behind the medial epicondyle, then in between the two heads of flexor carpi ulnaris, obviously supplying this also, running in the anterior compartment of forearm, passing superficial to the flexor retinaculum through the canal, which will tell you that is Guyon's canal, dividing into superficial and deep branch. Well, ulnar nerve is a dominant nerve of the hand. So ulnar nerve is not supplying much in the forearm. There is very few things to be supplied by the ulnar nerve in forearm. One, it is already done, that is flexor carpi ulnaris, and it is also going to supply the flexor digitorum profundus. But this time, which half we are talking about? It's the medial half of flexor digitorum profundus. Lateral was by the median nerve. Let me highlight that. Medial half of flexor digitorum profundus. Then we said after passing flexor retinaculum, after crossing the flexor retinaculum, it is going through this canal called as a Guyon's canal. Guys, what is Guyon's canal? It is a canal which is present deep to the ligament called as a pisohamate ligament. From the pisiform to hamate, there is a ligament, and that ligament is called as a pisohamate ligament. So it is going deep to that. So Guyon's canal is the one which is present deep to pisohamate ligament. It is passing deep to the pisohamate ligament, dividing into superficial branch and deep branch. Again, no problem with that. See, superficial branch is going to supply the superficial muscle, and the only superficial muscle that we have here is palmaris brevis. Remember, out of the four hypothenar muscle, one was the subcutaneous muscle. So that subcutaneous muscle is supplied by the superficial branch. Although it can be a good question that what is the only muscle in hand supplied by the superficial branch of ulnar nerve, and that is palmaris brevis. And yes, the deep branch will take care of the remaining all the muscles. So remaining hypothenars, remaining all interossei, remaining lumbricals, that is L3 and L4, L3 and L4, remember the bipinnate lumbricals, and it finally supplies the last muscle to be supplied by the ulnar nerve is the adductor pollicis. Last muscle to be supplied with the ulnar nerve. So basically, ulnar nerve supplies the adductor pollicis and ends. That is the end of the ulnar nerve. And because it is the end of the ulnar nerve, the nerve goes inside and just like ends there. That's why the adductor pollicis muscle, it is also called as the graveyard of ulnar nerve. It is also called as a graveyard of ulnar nerve. Well, graveyard is the place where you goes and never comes out. That's what the ulnar nerve is doing. It is just going and ending in the adductor pollicis, so we call it the graveyard of ulnar nerve. So here are the main points of the ulnar nerve: that it passes behind medial epicondyle, between the heads of flexor carpi and laris, supplies FDP medial half in the forearm. In the hand, it is taking care of majority of the muscles, right? Once again, just like median nerve, we also need to discuss here that what will happen if there is a higher injury or lower injury. Like higher injury somewhere here, let's say if the injury is because of the fracture of medial epicondyle, or if there is a compression between the two heads of flexor carpi and laris, so that is a higher injury. Lower injury, let's say Guyon's canal, it might get involved in the Guyon's canal. Guyon's canal syndrome is there, or laceration injury of the wrist, whatever, if the injury is here. So higher injury and the lower injury. Now again, discuss it and then we'll write about it. Guys, whether it is higher injury or lower injury, now one thing is there, even if the injury is here at this point or even higher, majority of the interossei and lumbricals, if not all the interossei and two lumbricals are involved. If all the interossei and lumbricals are involved, that one common function of the finger which is affected, which is done by the lumbricals and interossei, which was this function, remember that? Lumbricals were doing it and interossei were doing this. So this will be lost, and that will lead to the claw hand. So in case of ulnar nerve injury, there will be a claw hand. Yes, we call it ulnar claw hand. Why we are calling it ulnar claw hand? Why there is not a prominent claw hand on this lateral side? Because only two lumbricals are involved. Two lumbricals are still working. Median nerve supplies L1 and L2. Ulnar nerve supplies L3, L4 and all interossei. So claw hand will be there, and that is more of a ulnar claw hand. Let's say this is ulnar claw hand here. The point is, if let's say again, if I'm your patient, I come to you with the ulnar claw hand, will you see the prominent ulnar claw hand in case of distal injury, or will you see a prominent claw hand in the proximal injury? As a general perception, obviously when the injury is higher, the more muscles are involved, so that should be like more prominent. If the injury is lower, the less muscles are involved, so it should be like weak claw hand or something. But no, not in case of ulnar nerve. And that's why I'm sure you heard of the term called as the ulnar paradox. So in ulnar nerve, it is kind of ulta, it's opposite. If the injury is distal, you have more prominent claw hand. If the injury is proximal, you have less prominent claw hand. And why it is so? It is because of this muscle. Let's understand this, guys. Flexor digitorum profundus is the muscle which is causing this ulnar paradox. Okay. Now, imagine if the injury is, if I say injury is at this point here. If the injury is at this point, then obviously the claw hand is there, but which muscle is working? The FDP is working. Now, if your hand is already in what position? In the claw hand position. And imagine your flexor digitorum profundus is working, is active, because of which there is more flexion at the distal interphalangeal joint and the claw hand will be more, like this. But if the injury is higher, somewhere at this point, let's say medial epicondylar fracture, so claw hand is again there. But because of the higher injury, which muscle is also gone? FDP is also gone. So we do have a claw hand in the higher injury, but because flexor digitorum profundus is also involved, so there is no flexion at the distal interphalangeal joint, and that will lead to the less prominent claw hand. So claw hand will be there, but that will be less prominent with respect to when we saw it in the distal part. In the distal part, it was more prominent here. And who's the muscle in here for all this? That is FDP is the one which is responsible for this. This is what you call as a ulnar paradox. Let me write that for you. Ulnar paradox. So higher ulnar nerve injuries. Higher ulnar nerve injuries. What could be the higher ulnar nerve injury, guys? Medial epicondylar fracture. It could be a cubital tunnel syndrome. See, I told you. If I just take you back here, This space between the two heads of flexor carpi and laris, that tunnel here is called as a cubital tunnel. Please be very, very careful here. When we said cubital fossa syndrome, it was median nerve. Now we're saying cubital tunnel syndrome, it has to be the ulnar nerve involvement. So difference. So whatever the reason may be, if it is a higher injury of the ulnar nerve, higher injury, ulnar nerve injury, will have less prominent claw hand with respect to distal injury, or you can say in comparison to distal injury. And the reason, because as FDP is involved in higher injury, and because FDP muscle is involved in the higher injury, so there is no flexion at distal interphalangeal joint. I'm writing IP, distal interphalangeal joints. And because there is no flexion at the distal interphalangeal joint, which is a function of FDP, so obviously the claw hand will look less prominent. If you just straighten up this distal interphalangeal joint, this looks like a less prominent claw hand. If there is a flexion at the distal interphalangeal joint, this definitely looks like a more prominent claw hand here. So that is what the ulnar paradox is all about. Paradox is like ulta. So higher injury, less prominent. If it is a distal injury, it will be a more prominent claw hand. That is what is the meaning of the ulnar paradox. So this is about the ulnar nerve and the injury of the ulnar nerve in the higher level as well as the lower level.